Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this Soundbites module, entitled Part 1 of Bedside Ultrasound of the Aorta, we're going to focus entirely on the detection of abdominal aortic aneurysms. Now, this application of bedside sonography is definitely one of the most crucial ones for the emergency physician, as the detection of an abdominal aortic aneurysm can be life-saving at the patient's bedside. Detection of a rupturing abdominal aortic aneurysm can allow for rapid diagnosis and treatment of this condition in unstable patients without undue delay in the emergency department, such as unnecessary testing with a CAT scan or unnecessary resuscitation with multiple units of PAC cells. This patient needs rapid mobilization to the operating room. So I've divided this module up into aorta ultrasound parts 1 and 2, as there's a lot of material to cover within the realm of aortic ultrasonography. In this module, entitled Part 1, we're going to start with a review of the anatomy of the aorta. We'll then move on to learning how to perform the ultrasound examination of the abdominal aorta, and we'll learn the branches of the aorta that come off that we can see on bedside sonography. We'll then learn to understand the interpretation of the ultrasound images that we're obtaining using bedside sonography. Let's discuss a clinical case that highlights the utility of bedside ultrasound for abdominal aortic aneurysm. Our patient is a 72-year-old male presenting to the ED complaining of back and flank pain for several hours. He has a past medical history significant for hypertension, and his vital signs on your evaluation include blood pressure of 70/40, very hypotensive in a patient whose usual systolic blood pressure is 160 to 180. He has a heart rate of 110, a respiratory rate of 24, and a temperature of 100. On physical exam, he has a protuberant abdomen with generalized tenderness to palpation. As you think about the case, what's your differential diagnosis and what's your immediate action plan to best meet the needs of this patient? Well, high on your differential diagnosis are going to be the vascular causes of abdominal emergencies, and rupturing AAA has got to be high on the list here. As it's the vascular causes for abdominal emergencies that can rapidly kill your patient, a rupturing AAA must be immediately evaluated at the patient's bedside. And unfortunately, due to the fact that the patient is hypotensive with very unstable hemodynamics, he's a poor candidate for extensive imaging like a CAT scan, where you have to move him away from the resuscitation area for imaging. Perhaps a better practice plan in this patient is to initiate immediate resuscitation with 2 wide-bore IVs, giving him fluid and perhaps blood, and to perform a bedside abdominal imaging with ultrasound to look for an aneurysm. As you look with bedside ultrasonography, you find a very large abdominal aortic aneurysm. So the presence of a AAA with hypotension mandates immediate surgical consultation for rapid triage to the operating room. And if the patient has a rupturing AAA, the patient will not be stabilized until a vascular surgeon controls the hemorrhage with clamps and/or a graft. Unnecessary delay in the emergency department for transfer of this patient to the operating theater with extensive imaging like a CAT scan, or undue resuscitation with multiple units of PAC cells may result in a poor patient outcome, as he really needs vascular surgery control. Let's begin our discussion of abdominal aortic aneurysms with a review of the anatomy of the aorta essential to bedside sonography. Here we see the paired tubular structures that exist within the abdominal cavity, the inferior vena cava as seen towards the patient's right side, and the abdominal aorta towards the patient's left side. Recall the branches of the aorta. The first major abdominal branch, the celiac axis, composed of the hepatic artery, the splenic artery, and the left gastric artery. We see the next abdominal branch, which is the superior mesenteric artery. And notice that the superior mesenteric artery, or the SMA, courses off just above the left renal vein. We see here that the renal arteries come off just at about the level of the mesenteric artery. Thus, we need to pay particular attention to this portion of the aorta, as this is where the majority of aneurysms will be located. We see the bifurcation of the aorta at about the level of the umbilicus into the paired iliac arteries. And we see here also that the IVC branches into the iliac veins at this point. Now let's review the probe positions for sonography of the aorta. Generally, we're going to begin with a short axis configuration, and as shown in probe position 1 in the pictorial to the right, the best place to begin is to place the probe at about the epigastric area with a marker dot over towards the patient's right. This will pick up the superiormost abdominal aorta as it emerges from the thoracic cavity. Press down firmly to displace bowel gas and to image the spine. Right on top of the spine, you'll see the abdominal aorta. Once you visualize the aorta, slide the probe down to probe position 2 above the umbilicus so that you can image the entire abdominal aorta all the way down to the umbilicus at the level of bifurcation into the paired iliac arteries. It's always a good thing to image body parts in two planes, and so we should complete the exam of the aorta by imaging in the long axis configuration. Now, I should have said first right up front that it's best to use a 3 megahertz probe for this examination, and one can use a curvilinear probe as we're not struggling to look through ribs. So place the probe first in probe position 1 to get the first glimpse of the aorta from the long axis configuration in the epigastric region. This will image the most superior part of the aorta, and you'll be able to see the celiac axis and the superior mesenteric artery. One can then move the probe down to probe position 2, sliding it down to the area above the umbilicus to image the full extent of the aorta in the long axis configuration. At about the level of probe position 2 is going to be at about the level of the bifurcation into the iliac arteries. So this should complete our examination of the aorta. Now, if we're struggling to see the aorta from the anterior planes as shown here in probe positions 1 and 2, we can always look from the right hepatic window as shown in probe position 3. Place the probe over at about the level of the right upper quadrant trauma fast exam with a probe position towards the patient's head. One can then image the aorta by angling the probe anterior to the kidney to see the IVC and aorta in long axis configuration. Here's a video clip to further review the ultrasonic exam of the abdominal aorta. Recall the surface anatomy of the abdominal aorta, and we can pick it up just at the area of the subxiphoid process of the sternum. And there's going to be about the level of bifurcation into the paired iliac arteries at about the level of the umbilicus. So generally a good starting point is going to be just below the subxiphoid process. Begin with the probe oriented in the short axis configuration. There I'm just motioning to the marker dot of the probe, which should be located over towards the patient's right side. Now here we may have to push down a little bit harder to displace bowel gas and get a good view of that aorta as it emerges from the thoracic cavity. On the screen we can see the spine posteriorly, and there's the aorta seen anterior to the spine. So we want to image the aorta all the way down to the umbilicus, and as we come down, sliding the probe down the midline, we may have to displace bowel gas by applying firm pressure with the probe. Now remember that it's important to scan all the way down to the umbilicus to image the aorta from the topmost portion at about the level just above the celiac axis to the paired iliac arteries. We should always complete our exam of body structures by looking in another plane, and here we're imaging in the long axis configuration with the probe marker towards the patient's head. Here I'm just going to put Doppler flow onto the image here to show turbulent flow within the aortic lumen. This ultrasound image shows the proximal aorta just below the subxiphoid tip of the sternum. The probe is configured in a short axis orientation with the marker towards the patient's right. Our first landmark will be the spine. Notice it has a hyperechoic or bright appearance posteriorly in the image here. On top of the spine we see the inferior vena cava towards the patient's right side with its phasic pulsations, and the aorta towards the patient's left side. We can further distinguish the two structures by applying Doppler. And in this video clip, we have color flow Doppler applied towards the image. We see the spine, the posteriormost structure towards which our eye should go to orient ourselves towards the IVC and aorta. Notice the inferior vena cava lying on top of the spine towards the patient's right side. And we see the phasic pulsations of blood with respiratory variation. Notice that it almost collapses at times during respiratory pattern. We see the aorta over towards the patient's left, and note the steady pulsations of blood with each heartbeat. Let's now closely inspect the celiac axis. Now the celiac axis has the ultrasonic appearance of a seagull sign. It's the first major branch of the abdominal aorta and can be commonly seen on bedside sonography. It's made up of the common hepatic artery, the splenic artery, and the left gastric artery, although the left gastric artery is usually not visualized on bedside sonography. Let's look at the images here towards the right, and towards the top we see a B-mode or grayscale image showing the seagull sign. We note the inferior vena cava and aorta just above the spine, and we note here coming off the aorta the celiac axis. And we notice the seagull sign as it has the appearance of a seagull with wings in flight. Notice the hepatic artery branching over towards the patient's right and the splenic artery branching over towards the patient's left side. Let's look towards the bottom here, and we see a Doppler sonography image of the celiac axis, and again we see the aorta, and coming off the aorta we see the celiac axis with the hepatic artery going towards the right and the splenic artery going towards the patient's left side. This is a video clip showing the celiac axis in action. Again, we're going to orient ourselves by looking for the spine, that hyperechoic bright area towards the posterior aspect of the image. We see the inferior vena cava over towards the patient's right side, as noticed here, and over towards the left we see the aorta with the celiac axis coming off. Notice that it has the appearance of a seagull in flight. And notice that the wings of the seagull will be made up by the hepatic artery going towards the patient's right side and the splenic artery going towards the patient's left side. The left gastric artery, the third artery coming off the celiac axis, is not well seen on bedside sonography. Here's a video clip showing Doppler sonography of the celiac axis. Again, we see the spine towards the posterior aspect of the image, the inferior vena cava located over towards the patient's right side, and the aorta located towards the patient's left side. We see the branching wings of the seagull coming off as the celiac axis, and notice the pulsations with Doppler sonography. Recall the hepatic artery branching over towards the patient's right side and the splenic artery going towards the patient's left side, making up the wings of the seagull. Next, let's turn to a discussion of the second major branch of the abdominal aorta, known as the superior mesenteric artery, or the SMA. Now, the SMA is wrapped in fat and has a bright or hyperechoic rim on bedside sonography. The renal arteries come off the aorta at just below the level of the SMA, but may be difficult to visualize with sonography. But it's important to realize that most AAAs are going to be infrarenal, so this portion of the aorta is where we need to closely examine for abdominal aortic aneurysm. Now let's take a look at the ultrasound images to the right, and we see a B-mode or grayscale image towards the upper part of the right side here. Note the spine, and on top of the spine, the inferior vena cava over towards the patient's right, and the aorta towards the patient's left side. We see the classic appearance of the SMA with its bright or hyperechoic rim. Notice that the splenic vein arches on top of the SMA. We see the Doppler image towards the bottom aspect of the picture, and we see the classic appearance of the SMA coming off the aorta with its hyperechoic rim. Here's another short axis view of the proximal abdominal aorta. I have the probe configured over towards the patient's right side. We see here the spine, which serves as that most important landmark for referencing the large vascular structures within the abdominal cavity. We see the IVC towards the patient's right and the aorta towards the patient's left side. Let's take a look at the branches of the aorta, and we can see the many branches, the celiac axis, as well as the SMA. Here's the celiac axis, the seagull sign, and there goes the SMA with the splenic vein wrapped on top. So celiac, SMA, splenic vein, and what's interesting is we freeze this image down, we can actually see the SMA right there with its bright or hyperechoic rim, the splenic vein arching on top of the SMA, and the left renal vein we can see coursing just below the SMA. Notice we actually catch the right renal artery coming off the aorta and coursing over towards the IVC. Here's another view of the proximal abdominal aorta, the spine posteriorly and the aorta anteriorly. Let's look at the branches here, and we see, first of all, there goes the seagull sign or celiac, and there's the SMA coming off. Notice again that that SMA is wrapped in that hyperechoic mantle. And we see the splenic vein wrapping on top of the SMA. Here we're just going to freeze that down. We'll see that SMA again and the classic look of the splenic vein that arches on top of the SMA. This is a short axis view taken with Doppler sonography, looking specifically at the SMA. We see the aorta pulsating towards the posterior aspect of the image right above the spine, and here we can see the superior mesenteric artery coming off of the aorta right there. And notice that it has pulsations indicating good Doppler flow. So here we'll freeze that down, and we see the classic appearance of the SMA with its bright mantle and the splenic vein arching on top of the superior mesenteric artery. So let's reinforce the proximal branches of the aorta with this video clip. We see the hyperechoic spine and the aorta on top. There's the celiac axis or seagull sign, and there's the SMA coming off with a hyperechoic or bright rim. So celiac to SMA, and we'll go ahead and freeze that image down, and we see the splenic vein arching anterior to the SMA. Notice in this video clip we actually catch the right renal artery coming off just to the side of the aorta, branching over towards the patient's right side towards the IVC. To complete your examination of the aorta, it's important to look all the way down to bifurcation of the aorta into the iliacs. Here we see the spine, and lying right anterior to the spine, the aorta. As we scan more distally, we actually can see here the bifurcation into the paired iliac arteries. Note that the aorta becomes more superficial as we scan more distally, so we may have to readjust our depth of the image. Here we see the paired iliacs lying on top of the spine, and it's important to complete the exam by visualization of aorta all the way down to iliac arteries, as some aneurysms of the aorta will continue down into the iliac artery. Here's an image of the distal aorta at bifurcation with Doppler sonography. We notice the spine, and on top of the spine, the IVC to the patient's right, and towards the patient's left, we see the aorta. Let's put that into video play, and we see the Doppler pulsations of the aorta, and right there, we see the bifurcation into the paired iliac arteries. So Doppler can help you in visualization of the vascular structures, and here we see well the bifurcation of the aorta into the paired iliac arteries. And I'll still that image down, and we can well see the iliac arteries, the right and left, just to the side of the inferior vena cava. This is a video clip in which I was able to capture all the major branches of the abdominal aorta. So let's reinforce those learning points, starting here with the celiac axis, or the seagull sign. Next branch, there goes the SMA, and there's the renal vein coursing over the aorta. Notice that the aorta becomes more superficial as we scan more distal down to umbilicus, and there's the paired iliac arteries. So again, there's celiac, followed by SMA, there's renal vein. Remember, renal arteries come off at about that level. And as we scan more distally, we see the bifurcation into the paired iliac arteries right there. It's always important to look at body structures in two planes, so here's the aorta in long axis view. We see superior to the left and inferior to the right. Notice the very muscular walls of the aorta and the pulsations with each heartbeat. And we see the branches here of the proximal aorta. We see the celiac axis arching more towards superiorly or towards the head, and we can see the superior mesenteric artery, the SMA, arching inferiorly. So a nice view of the aorta and long axis view. And remember that it's important to look at that aorta in both short axis, as we reviewed previously in this module, and long axis as seen in this video clip. We can use Doppler sonography to further investigate the aorta and to differentiate that from the paired IVC just to the right of the aorta. Here we see that long axis view of the aorta. Notice the classic pulsations of the aorta with Doppler sonography. And we can see the branches of the aorta, the celiac axis, arching superiorly, and we can see the superior mesenteric artery arching inferiorly. Note that this is a mid-sagittal view, and we can see it the liver anterior to the aorta. One potential pitfall in the imaging of the aorta in the long axis configuration is to mistake the aorta as the inferior vena cava. For this reason, I've juxtaposed two images showing the aorta to the left here and the inferior vena cava towards the right. Notice that they have very different appearances in long axis configuration. Let's look at the aorta towards the left and notice that it has much more muscular walls, and notice the pulsations with each heartbeat. We can also see some of the branching arteries coming off the aorta. Notice the IVC towards the right has a very different appearance with thinner walls that open and close in phasic type configuration as the patient breathes. We can further differentiate the two structures by applying Doppler sonography. Notice the Doppler pulsations of the aorta, and we see pulsations with each heartbeat. And notice the very different pulsations within the inferior vena cava. We have more of a steady venous hum, and notice that the venous waveforms will change as the patient breathes. As the patient takes a deep breath, more blood will enter into the chest, and the inferior vena cava will tend to close in diameter. So very different appearances of the aorta and IVC in long axis configuration. One final pearl for the imaging of the aorta is to use the right hepatic window in cases where you're blocked from excess bowel gas from an anterior approach down onto the aorta. Using the right hepatic window employs the liver as your acoustic window onto the inferior vena cava and aorta and will allow for a long axis view of the aorta. Basically, the probe is placed in a similar configuration as for the trauma-fast right upper quadrant view, but the probe is angled more anteriorly over the kidney to look through the liver and to see the IVC as the first structure and the aorta more posteriorly. Notice here we get a pretty good view of the aorta in long axis posterior to the IVC and can get some sense if there's an aortic aneurysm present. In conclusion, thanks for tuning in for the Soundbites module covering Part 1 of bedside ultrasound of the aorta. Bedside detection of abdominal aortic aneurysms is definitely one of the most crucial applications of point-of-care bedside ultrasonography for the emergency physician, as detection of a rupturing AAA can be life-saving for your patient. And hopefully by covering this module, you now understand the anatomy of the abdominal aorta, how to perform the ultrasound exam performance of this structure, and how to interpret the ultrasound images of the aorta that you will obtain using bedside sonography. So I hope to see you back in Soundbites module part 2 of aorta ultrasound, where we'll focus entirely on abdominal aortic aneurysms. So I'll look forward to seeing you back in the future as Soundbites continues.